right, Justin, let's go ahead and get started. First things first, just introduce yourself, your position, a little bit about you.
Yeah. So I'm Justin Day. I'm the Chief Medical Officer at Vive. We opened up, I don't know, about 6-7 years ago. And my background is mostly in hospitals and inpatient care for mental health. I worked with adults, teens, and geriatrics as well. And I'm a psychiatric nurse practitioner, and yeah, that's pretty much all I've done is mental health, and really wanted to get into helping the youth. That's where I really feel like I connect well with them. So
That's awesome.
that's kind of where we started.
I love that. And I feel like as much as we've moved forward in our understanding of mental health, I feel like there's still a whole bunch of misunderstandings about it.
A lot. Yeah, from everywhere. Parents and professionals both kind of misunderstand it a little bit. Yeah.
Let's just kind of dive into some of the outcomes of maybe some past clients that you've experienced, you know what I mean? And some of what type of benefits have come from, helping them.
Yeah.
Survive.
I mean, if you think about it, it's not uncommon,
Mhm.
right? So about 1 out of 4 kids are going to struggle with some type of mental health problem in their life. And so when parents see like, oh, that's not my kid, right? It can't happen, or what's
Mhm.
going on. It should be more normal, right? It does happen, especially in this day and age with technology and so much stress in our lives, that you're going to see some, and it's okay. Like, we all have, just like medical problems, it's pretty normal, and we can address it and help each other out. So I think for outcomes, I mean, we deal a lot with, there's kind of 2 main things that parents are looking for. And it's that one is the crisis moment, right? There's danger to themselves or other people, and they don't know what to do. So they'll typically take them to an ER, right? And say, what do I do? How can we help? And they'll usually direct them to us. And so from an outcome standpoint, we're really looking to stabilize and kind of get them back into a safe place. How can we help them take them out of that risk of self-harm? So we give them a safe environment, and then we can work with what's getting them to that place, helping the parents understand. And that's kind of the second part, is parents don't understand why they got there and how they got there, or even what to do with it. So that's, from an outcome standpoint, we're really trying to help educate the families as well, and really help them understand that, one, it's okay, like, we can help them through it. This is part of life, right? They're going to have stressors and struggles, and give them a clear path on how to kind of address these concerns in a safe manner and keep them safe at home.
That's awesome. Do you, because I feel like too, like, we just want something fixed. We want the problem just instantly solved. And it's like, okay, they spend time, they might go through some treatments with you guys. And the realization is that it's not as simple as now they're better, right? It's not like a cold, or something like that.
Yeah.
Talk a little bit about the expectations that families should have after their, the treatment of their children.
Yeah. Well, I'll first kind of say that Vive's a little bit different in the way we treat, in our just process model, right, for inpatient. If you kind of compare us to other inpatient hospitals, the traditional treatment is going to be 3 days, 7 days in an inpatient setting, and then they go back home. Our model is a little bit different, where we offer that same level of care, but we also offer more of a step-down approach, and it can lengthen that time frame to where we're not only kind of doing that quick fix to stabilize, and here's a new med, here's a quick therapy session, okay, now we can go home and you're okay. We feel like it's not quite enough, especially in adolescents and families, to help them understand, and is our changes, are they working? Are we really addressing the problems? So we can now address our typical length stays around 4 weeks, 30 days, and it can be shorter, but it can also be longer depending on what they need. And so we can do that kind of step down approach and really help them stabilize, right? Where you're going to address medications and do that therapy. But now we're going to evaluate, is that change really helping? And is that the real root of the problem? Or is there some underlying trauma? Is it some other issues that we're now discovering that if you only had 3 to 7 days, you may not even get to? So we really wanted to kind of extend that stay and really create a model, our Vive process model, where we're addressing each concern and are they safe enough to really get back home and in the community with the tools that they need, but also the family and how they can address that as well.
I love that, because I do feel like just with like my own personal life, I have had friends go into the hospital for mental health reasons. Yeah. And there's also like a problem of that they aren't better, that it was kind of like, hey, yeah, we're just going to kind of get you in and get you out.
Yeah, get the Band-Aid on it.
And it's like, man, I feel like they should have had more time. Like they should have, you know what I mean? Anyways, I think that's just so awesome that Vive does that and actually takes the time and is like willing to say, no, we're going to make sure that the things are working, that they're responding correctly. So I think that's like awesome comfort that you guys offer.
Yeah.
That's pretty rad. I guess a common question as well would be, how do I know if Vive is the right fit for my kid?
Yeah. Yeah, I mean, I think if your kid, right, if you're having struggles in mental health that can't be addressed safely at home. So they're at home, you're working on things, you're going to weekly therapy appointments and your outpatient providers, and maybe you're doing some of that basic med management stuff, but they're still not safe and it's becoming more of a crisis and a danger where they could end their life or hurt somebody else or potentially overdose on, substances. I mean, really that's where we come in. So if it can't be managed on an outpatient level, then we have multiple levels of care where we can manage and help. One priority obviously is keeping them safe and stabilize that piece, but then create that plan for that transition back into the community. And we'll help them, right, with aftercare appointments, because sometimes they're just not getting the care they need. Maybe it's too little or the wrong type of outpatient care. So we're really looking at, okay, do we need to pivot and go to more intensive care, maybe like an IOP program where they're going multiple times a week, or they just need more of a reset and it's not working. So we'll kind of completely change medications or treatment modalities and then create a new plan for them.
Do you guys keep track of like the clinical outcome? Like, do you guys have like all that data and do you guys provide that and are open about it? You know what I mean? Kind of so people can see the success rate or anything like that?
Yeah, we love data. I mean, we like lots of data. So we're always looking at different measures and outcomes. When they admit, we do several different assessment tools and kind of where they're at when they get there. And then same thing throughout their stay and when they discharge as well. So we can get a pretty clear picture of progress. And I don't remember the numbers right in front of me, but I from a suicide standpoint, I know if they came in with that, I mean, our leaving and decreasing in success there, I mean, it's in the 90s percentile. So we're pretty successful with that. And, I mean, that's kind of what we do, right? We're really trying to make sure that they don't leave with the same problem. So if they're not ready, then they're not ready. And sometimes they need more time than even what we can offer, right? So we can help them with more of a longer term treatment center or something that still can continue to work on some of these things.
That's awesome. Is there anything that, and maybe there's not, but is there anything that that you wish that the parents would know that's not shown in the data, right? Anything that's like, other processes or other things that like, because they might say, oh, well, some people are just very left brain and they just want to see like numbers, whatever. But is there anything that's missing from the data that you also want to address?
Yeah, I mean, because mental health's a little bit more of I kind of describe it more of a puzzle, right? It's not, here's your straight protocol and here's your infection, right? And then it's gone. And we can measure that, like you don't have it anymore. It's a little bit more complex, right, than your kind of more typical medical problems. So the data will show some improvement in some areas, right? We can measure certain things, but I mean, therapy's a really wide net, right? And so there's different ways to connect with people. Some kids just won't connect with certain providers, right, in outpatient or even with us. So you might have to pivot with a different provider. And so from a parent, we want them to kind of understand, like, we're here to help, but create a more of a long-term plan, and it's not, here's a medication and you're going to feel better. You're never going to have thoughts of self-harm or suicide. You're never going to feel depressed anymore. That's not realistic, right? You're going to still have moments, but we're really trying to teach how to address those concerns, which you sometimes can't fully measure. So we're kind of seeing, how do they respond to triggers and how do they respond this way? And a lot of it's more subjective than it is objective data.
I love that. And I think it's important for everyone to realize it's not A plus B equals C all the time.
Yeah.
And I think, the nuances of everyone else, I mean, just like, because everyone's so different. Everyone has, like you're saying, different triggers and stuff like that. So I think that's cool. I think it's cool for people to understand that Vive is going to do the best in care, but also like really figure out all of those little things so that when things do come back up, you know what I mean, or flares or whatever it is, that there's a long-term plan, which I think is the best route.
Yeah.
That's cool. Next question that I have here is, how often is my child seen by a provider?
Yeah. I mean, typically with, any hospitalization, they're going to be seen once a day on like a hospital level of care. And so we'll still do that, right? We still have our psychiatric providers meet with them every day. Sometimes it's even twice a day. So if there's they have an incident, right, that maybe requires a safety intervention, then a lot of times we'll have them meet with them again, just kind of process that incident and see kind of what got them there and if there's anything we can do in that time frame, because it's way easier to see the problem when it's happening and address it right then. And then when we go to a more what we call residential level of care, so it's kind of like a subacute, where we're still continuing that stabilization, but it's less severe, right? It's not as active, and they're not actively trying to self-harm or hurt others. Then we're looking at the standard, right, from like insurances and other treatment centers is at most once a week, sometimes even once a month. We're seeing them every day of the week, and weekends just kind of as needed if they have incidents. And then we have a day treatment program or partial hospitalization. So they're there 5 days a week, and we see them 3 of those days. So we're still involved. I mean, our main goal, right, is to far exceed the standards in this industry. Because, when you're trying to make active change, once a week to once a month is just not enough. We need to keep closer eyes on, and so we can see if they're having side effects to the medications, and even if they're subtle, right, not significant, or we're not quite getting the outcomes that we're wanting, or do we need to adjust dosing? Do we need to adjust the medication itself? And from a therapy standpoint, right, they're doing the same thing with maybe their treatment goals, right, and what we're modalities that we're using to address those. Maybe it's not working. Maybe we need to do something different. And not to mention, we have several other additional treatments that aren't typically offered at other places.
That's awesome. Do you find, because I just think like already understanding that you guys are going to go above and beyond, right? I think of often when someone's like extracting a tumor, a doctor is extracting a tumor, they go a little even past the point of what they can see.
Yeah.
And I feel like it's kind of similar with what Vive's doing with the mental health. It's like, no, we're going to make sure even past the point so that there was nothing residual still existing.
Yeah.
Or problems that could be solved with, professional help.
Yeah. I mean, Yeah, we're definitely focused a lot on quality and not just kind of that numbers quick. I mean, there's so many examples, right? I mean, our practitioners typically, like our hospital for psychiatric care, your practitioners are there till 2 or 3, p.m. Right? They come in early, they leave early. Where ours are there pretty much through the evening, usually 7, 8ish, and that's because there's just a lot more we want to get done and really be there for those incidents. And but I mean, there's so many examples, right? We want to do not just the basic treatments. We want to offer a bunch more additional treatments that aren't maybe your traditional, quick medication. While we still offer all those things and it's part of treatment, just because we look at the evidence, right? And we want to find what's evidence-based and what's good treatment. But there's so much more out there than just A and B, right? There's not just one or two tools. There's so many.
That's awesome. I love that. Let's talk some of the specifics. You mentioned a little bit of like suicidal tendencies. What about something like eating disorders? How is that? How do you guys handle that type of thing?
Yeah, I mean, and I think I've mentioned suicidality and harm to others, but there's so many mental health, disorders, and we really grasp all of them. So like, yeah, eating disorders, we get quite a bit, right? Restricting food, and it's more the thought process behind them. We're not a long-term or a longer-term eating disorder where we're managing feeding tubes all the time, and we're not so much that, but it's more that the thought process behind it. And so kind of that body dysmorphia and body image they're really struggling with, and it's typically related to some type of OCD or depression, anxiety. And so we're trying to find what's the root cause that we can address these things. And yeah, I mean, there's a lot. So eating disorders, bulimia, anorexia, we have a full-time dietitian that's there every day. So she's meets with the kids and works with our treatment team, and she comes to all our meetings every day. So we're pretty closely connected with her and how to manage their thoughts of eating, right? And sometimes we need to do smaller meals throughout the day. There's so many different techniques that you can use. So on top of, eating disorders, I mean, we look at psychotic disorders, with schizophrenia or bipolar. We have mania. There's substance use disorders. I mean, we kind of see it all. A lot of trauma. I mean, it's sad because we deal with teenagers as all, and it's actually getting younger. I mean, we've had as young as 9 in our facility, and it's pretty significant what we're seeing, and there's not a lot of places out there that can help at this age. So we're really trying to grasp as much as we can, that because our model is built to treat pretty much all the psychiatric disorders.
That's awesome. I feel like especially people looking for someone to understand that there's a nuance to it, and it's not just, here, take this medication. That you guys are saying, like, even with the eating disorders and such, it's like that, hey, there actually could be a solution before we go to the medication, right? It could be, like so like almost like a knot in a muscle. You know what I mean? It's like, hey, let's go through all of that and make sure that that's not what's causing it before we go to the heavy medication. Am I understanding that correctly? As far as how Vibe operates?
Yeah, and I'll kind of touch on medication stuff for a minute, because we see this a lot we get kids from other facilities all the time, long-term residentials that come from other hospitals to us, still not stabilized or still struggling with certain things, and I mean, they're only teenagers, and we'll get kids with 10 different medications already, and or they'll have 3 of the same type of medication, and so we look at polypharmacy as kind of becoming a problem almost, right? And so I think the quick answer, right, if you go to a hospital, they need something new. We need to add something. This one may not be working. But sometimes we haven't even really tried that medication either long enough, or we're not building up the dose long enough, or we'll just throw on, we have like 3 meds kind of in the same class. It's like, well, maybe this isn't the right reason. Maybe we need to dive deeper on what's going on. Is there some type of trauma? Is there, is there substance use involved? Is there just a family dynamic issue that hasn't been addressed? So there's a lot of things that we really need to look at. And so our kind of philosophy with medications is they're not a quick fix, right? They're really there to help you, stabilize, right? In most cases, right, you're looking to kind of help alleviate the symptoms that are presenting. It's not like, oh, depression, here's a depression med. You're looking at the symptoms of depression. Okay, so this symptom this medication works best with these symptoms of depression versus these other ones, right? But then also reducing the medication burden that these kids are having, because you're going to increase interactions, side effect profiles, or your risks are going to go up, and long term it's not any more beneficial than really trying to reduce. Sometimes we'll just start over and do a med wash. We're really trying to minimize the number of medications we're using while still addressing the issues that we see.
That's awesome. So if I understand correctly, like the medication is there to help alleviate, not fix, so that then a lifestyle can be changed.
Yeah.
Okay.
Yeah, and a lot of parents will ask, well, I don't want my kid to just be glued to a medication forever. I don't want them to be dependent on a medication. It's pretty rare we'll use any dependency medications. It's very rare, actually, with teens especially. But our goal is these aren't meds forever. You don't take them forever. So typically we'll recommend like 6 months to a year of stability before we look at decreasing or coming off a medication. And there are certain circumstances we would recommend, like, okay, this is maybe a case where long-term, like bipolar with mania, right? That's typically one you'll want to utilize medication, or psychosis that's not related to substance use or trauma, where this is kind of more of a lifelong disorder, and it's safer to manage those symptoms than not take a medication. But in most cases, this is more of a temporary fix while they build and learn the skills that they need, and their frontal lobe and brain develops further, that they can manage it on their own.
So I heard you guys that at Vive do injections.
Yeah.
Is that true?
Yeah, we are. I mean, we offer a lot, right? We do pretty much any treatment modality, and injections are pretty limited, right? So they're kind of the last resort when we've tried safety interventions, and we do, like physical restraints, and that's, again, very extreme. They're causing immediate self-harm, and they're an imminent risk to hurting someone else. So they're pretty rare, but they do happen. And all of our staff are trained on how to utilize them in a safe way. Injections are very last resort. So we're obviously offering oral medications first, and trying all these treatment modalities, right, that are going to be more therapy, de-escalation strategies. But yes, we do offer those, and those to keep them safe, or staff safe, and because that's obviously our primary goal.
Cool. No, that's awesome. Do you have any examples of a time when you guys would use injections or utilize those things? I don't know if you want to talk about that, or how much you want to talk about that, but
yeah. I think the biggest, like, for example, right, someone's aggressive, right, and they're either going after another client or a staff member. We may put them in a physical hold, right, to obviously keep that distance and safety. And they're really minimal, right? There are no pain points or anything like that. It's pretty comfortable, safe. I mean, uncomfortable, but safe. And then if they're in that hole, then they're still like just not calming down, fighting, refusing any type of oral medications, and it's going on for quite some time, and it's almost posing a safety risk to themselves in the hold. That's typically when we will start looking at an injectable medication. So pretty rare that we can't de-escalate and get to that safe point before then, but there are times where it may get to that.
I mean, I think that's great just to know that it does exist and not saying like, hey, we're never going to utilize something that actually could provide safety for themselves and everyone else.
Right.
Do you offer MAT options?
Yeah, so MAT is medication assisted therapy, and that's mostly for substance use and or detox, right, from consistent substance use. That could be benzodiazepines, opioids, alcohol. I mean, there's quite a bit that we can treat. And we'll utilize most of them. We don't do methadone. That's a lot more regulated and usually more an outpatient daily basis. But yeah, we've used Suboxone and others for safety. So, because there can be a danger, right, to coming off medications without being managed. And so we help them, one, just be comfortable getting through that, but also prevent some of those significant seizures and other options that can come with that.
I think, and you can tell me this is an important question, but I think it's like helpful for people to understand that their child could be exercising regularly, could have a good diet, could have good friends, good family life, and still have mental health issues. Can you kind of address that a little bit? So that, I think sometimes they hold the blame, or they think they're trying to find what to blame instead of they're just sick. You know what I mean? They just have something that needs to be, treated.
Yeah. It's actually fairly common, right? You'll get kind of all types of patients. You'll get those exact ones you're talking about. You'll get some that come from just horrendous family backgrounds and or crazy substance use their whole life. But then there's some that are just kind of more idiopathic, right? There's not a known cause. And it's the same in regular medicine, right? High blood pressure, sometimes it's idiopathic and it just happens. They're not overweight, right? They're exercising, they're eating healthy, but their blood pressure is still high. So yeah, we see that quite a bit. And obviously we're trying to build tools to prevent them from getting to the extreme unsafe part. Because we see this especially in teens, and they don't teach it in school, right? Therapy is not a class that you take in school. So they still need to learn how to manage those thoughts. But yeah, there's sometimes the thoughts do just occur.
No, this is awesome. Are there any other questions or things that you want to state that maybe it's a common misunderstanding, a common oversight, maybe it's something that people are surprised that you guys don't do or that you do? Is there anything like that we should know?
I think I'll touch a little bit on maybe some of the additional treatments that we do that are a little bit non-traditional, right? So we offer quite a bit, and one of our main core values is innovation, right? So we want to be more innovative than just here's the standard protocol and we're always going to do it. So we're always looking at what's the research coming out, what's the new data. And for example, we do ketamine assisted therapy, and we do it IV, and there's quite a bit of data coming out for treatment resistant disorders, especially depression or trauma, where they've tried multiple medications, they've been in multiple treatment centers, nothing's working, and parents in those cases are typically like, we don't know what to do. Like, we've tried everything, and so you could keep going, right? You can keep doing new hospital, new medication, or retry medications. And it's sad, even at teens, we see this quite often. And sometimes it's not even, you have to go through all that. There's certain cases where ketamine is a better option. And ketamine's been around forever. It's like the safest anesthetic out there. And so we use very small doses. We use it with therapy, so it's therapy assisted. And we've seen phenomenal results with that. Just life changing, where been stuck in kind of this rut and nothing can get them out to completely change, new way of thinking. And it's kind of like they're being reborn in new way of thinking. So, and we do what we call our circuit treatments. We do like oxygen therapy. We do these electromagnetic mats. We do transcranial stimulation or TMS treatments, and those are for depression, anxiety, OCD. We have autism protocols as well. We do hyperbaric oxygen treatments. So there's quite a few different things that you'll never see in a traditional psychiatric or mental health treatment setting, especially in an inpatient or residential. But the results are there, right? And the data's there. And so why not offer it to these families where they are feeling hopeless and stuck?
That's rad. Do you guys deal with common, that could even seem silly, misconceptions about a mental health hospital, right? Like, you know what I mean? Like, I think the movies have really painted a picture in a lot of people's minds about what's taking place, what it's like there. Are there any common things that you just like want to clear the air and like help people understand and get a real picture of what it looks like?
Yeah. We don't have straitjackets. That's not pretty traditional thing, is not a thing. I mean, they're pretty active, right? They're not like in this completely shut off, white walled building. We have multiple group therapies throughout the day. We try and keep them active and their brain engaged in learning. But we also want them to experience some stress and downtime as well. So because that's what they're going to deal with at home, right? They need to learn to be bored. They need to be triggered by other kids, and we want to help them how to respond to those. And so, yeah, I mean, you'll see, like, they don't watch TV all day. They don't, like, you'll hear a lot of these things, and yeah, it's pretty structured, and we try to make it as comfortable and home-like as we can.
Justin, well, thank you for your time today. Where can people go to find more about Vive?
Yeah, so they could always go to our website, vivetreatment.com, and then they could always call in to our admissions team. They're phenomenal at answering any questions that parents may have and directing them in the right direction. So
awesome.
I appreciate having me on.
Yeah, it's great. Thank you.